Hi, my name is Piedad Suarez, and today we are going to talk about medication-related osteonecrosis of the jaw. As we know, patients with HIV are more prone to develop bone density problems for different aspects, and including side effects of medication, especially antiretrovirals. They are in higher risk to develop fractures or avascular necrosis, so it is important that they are placed in any type of preventive medication. That could be vitamin D and calcium, or they can even go for need further treatment. The bone disease in HIV patients, there is documented that there is osteopenia and osteoporosis, and there is evidence that when they have combined antiretroviral therapy, it exacerbates bone disease reduction of the density of their bone, and especially when they are receiving therapy, and in particular tenofovir. So what I'm going to do in this presentation is basically I'm going to focus in a position paper from the American Association of Oral and Maxillofacial Surgeons that was updated in 2014. And the difference that they have this time is that the previous paper was about bisphosphonate-related osteonecrosis of the jaw. Now they extended to medication-related osteonecrosis. Basically, because the previous evidence that we had was only related to bisphosphonates, either if they were oral or IV, but now we found that not only bisphosphonates, but also anti-resorptive medications like denosumab, and also some anti-angiogenic therapies also can cause this type of problems. With the bisphosphonates, we know that they inhibit osteoclast activity and promote osteoclast apoptosis. But one of the problems that we have with this medication is that they bind into the bone and they stay there for longer periods of time. With the other medications, their effect on bone remodeling decreases within 6 months of treatment cessation. So it is important that we remember that the bisphosphonates can be given orally or parentally, and that they are used for the treatment of and prevention of osteoporosis and osteopenia. They are used to managing cancer-related conditions and managing also lytic conditions, especially multiple myeloma. The first time that bisphosphonate-related osteonecrosis was reported was in 2002, and in 2003, Max presented a paper documenting 36 cases that were associated with IV bisphosphonates. And what he noticed was that these patients were taking the medication for bone metastasis, and when debridement was performed, the condition worsened to increase amounts of exposed bone. So since then, we are seeing more and more often these characteristics. And at the very beginning, it was only documented for IV, but now we have reports also with a lot of patients taking oral bisphosphonates that also develop the condition. So in order to be diagnosed with a bisphosphonate-related osteonecrosis of the jaw, first, they have to be current taking the medication or have history of taking the bisphosphonate therapy. They have to have exposed bone in the maxillofacial region for more than 8 weeks, and no history of radiation treatment of the jaw or any area of the maxillofacial area. So why are the jawbone more affected? Well, one of the reasons is because they are always under constant remodeling. And also, if you remember, the oral cavity is not an sterile environment. And also, they are more prone to trauma external and internal, and more prone to have a bone exposure, especially if we associate it with extraction. So the American Association of Oral and Maxillofacial Surgeons reorganized the classification, and they gave the classification that you have on the screen. So having at no risk category, that were the patients that are using or being treated with bisphosphonate, either oral or IV, where no treatment is indicated, but we have to provide patient education. In stage 1, there is no clinical evidence of necrotic bone, but the patient complains of symptoms. At this point, probably pain medication or even antibiotics will be considered, because when you take the radiograph, you will see radiographic changes in the area. In stage 1, there is exposed bone, but there is no evidence of infection. So antibacterial mouth rinses are recommended, and the most common use is chlorhexidine, and we have to follow in quarterly basis, and we have to educate patients about the indications regarding the bisphosphonate therapy. In stage 2, there is exposed bone, and probably there is presence of fistula or evidence of purulent drainage. So the infection is evident. And for that, we will follow the previous recommendations, but we may need to add a symptomatic treatment with oral antibiotics and pain control. And in these cases, some sub-debridement of the tissues will be recommended in order to control the infection. In stage 3 is when you are going to have all the previous necrotic bone, but there is going to be a fistula that will be with a extraoral communication, and that will be very with extra. The fistula will be very evident, and again, the same treatment that from the previous condition, but in this occasion we have to add surgical debridement, and in some occasions you may be considering resection just to have a better long-term palliation of the infection and pain. In this screen, you can see the different stages. In the top, you can see that we have here the radiographic changes that we were discussing, but the bone is not exposed. So this is stage 1, where you see the exposed bone, but no evidence of infection. In this other picture, you see the exposed bone, and here the evidence of purulent material. And here, the stage 3, where you have the external fistula. How are we going to manage these cases? Well, the ideal treatment is that before you even prescribe this type of medications, the patient should have an oral health assessment, and all the dental work that is needed should be should start before the bisphosphonate therapy starts. That is in the ideal world, but if you cannot postpone that prescription, at least to refer immediately your patient. Either if we also need to know if they are taking oral bisphosphonate or IV. For what reason? Because if they are just for prevention of osteopenia or osteoporosis, or if they are for treatment of cancerous lesions or lytic lesions. And the duration is also important. It's important also to establish if they are in risk of other systemic conditions, particular other autoimmune conditions, diabetes, use of corticosteroids, if they are smokers, etc. There are other risk factors that are more related to the medications, and there are studies that show that in patients with cancer that they were exposed to solendronate and denosumab, the ranges increases between 50 and 100 times higher than patients that receive placebo treatment. Because remember that even though the incidence, it will be about 1%, because the bisphosphonates stayed in the bone for approximately 10 years, they are still on risk to develop conditions. Also, patients that are taking oral bisphosphonates, really depending on the exposure, if they are taking for more than 4 years, the risk to develop the conditions goes from 0.1% to 0.21% if they are taking for more than 4 years. So it really has a high peak based on the years that they are using. And there are other conditions like soft tissue toxicity and innate immune dysfunction. So here is a graphic of what I just explained, and you can see that if the patient is taking the medication only for 1 to 2 years, the risk is pretty much minimum. However, I do have patients that have been taking the bisphosphonates only for 3 months, and they develop osteonecrosis. 0.05, 0.051 if they are for 3 to 3.9 years, but look at the big change when they take the medication for more than 4 years. So another risk factors are related to the operative treatment. So that means that if they are having extractions or minor surgeries or implant placements, the risk is going to be higher. However, there is no data to the risk factors of other procedures like fillings or regular cleanings. Anatomic factors are also important. For some reason, the mandible has higher impact than the maxilla, and it's probably the quality of bone that we have there. And also, if they have other concomitant oral conditions, especially if there is a periodontal disease associated, and also with more reason if there is a tooth extraction. But there are other demographics and systemic factors that also cause an impact. Age, as we age, and since we are having more HIV patients living longer, the risk is also higher, and from postmenopause women as well. Anemia, if the hemoglobin is lower than 10 grams per deciliter, also uncontrolled diabetes, prolonged use of corticosteroids or angiogenic drugs, and of course if they are smokers. So the recommendations are, if patients are going to initiate intravenous therapy, that patients need to be educated about the risk, that all non-restorable teeth and those with poor prognosis need to be extracted, and if they have they need to complete all the necessary elective dentoalveolar surgeries before starting the IV treatment, and if it's possible to delay the therapy, that will be ideal. If it's not possible, at least it will be advised to wait until the epithelium has healed. If not, if you have to prescribe immediately, at least refer immediately to the dentist. Have your patient having the regular dental procedures in regular basis, so that there is no advancement or of the dental condition. And if they have full or partial dentures, they need to be also addressed, because if they have poor fitting dentures, they are also going to cause trauma and damage to the mucosa. For those that are already receiving the intravenous therapy, ideally we have to try to avoid extractions if it's possible, and for that probably we recommend root canal therapy, just to leave the root tip in the bone and seal the stem. And if they have been using the therapy for a longer time, sometimes it will be recommended to discontinue for a period of time. just to give a holiday to the bone. However, remember that the medication stays in the bone. And for those that are going to start just for the treatment of osteoporosis, usually they are going to take oral medication. The risks are going to be very small, less than 1%, but we have to educate our patients. And we also have to consider the duration of the therapy. And one thing that has been very popular in the last years is the use of systemic markers, but it's of the bone, and they really don't cause a major difference, so it's not going to be, it's not a recommendation that we do in regular basis. There is no evidence either that interrupting the bisphosphonate therapy alters the risk for osteonecrosis following extractions. However, if the patient has been using more than 4 years, we may want to consider to stop the medication or give a holiday drug for at least 2 months, just to see if we prevent the development of this damage. If the patient has any metastatic that we are suspecting or any other lesion, sometimes we have to do the biopsy because it could be just a metastasis. We should forego elective surgery, especially implants. Routine dentistry should be provided, but local and traumatic periodontal therapy with root canal just to avoid the extraction. Consider placement of stents in case that the patient has bone exposure, just to protect from trauma. And if the patient has already signs of infection, we have to treat with one of these options depending on the best that accommodates to your patient. Other antimicrobial therapies, as I mentioned before, are recommended. Sometimes we have to combine antibiotics and even consider adding antifungal medications. Recall is important just to follow up how the condition is under control or is advancing, because again, you may have to add another antibiotic. And remember that with bisphosphonate-induced osteonecrosis, the hyperbaric oxygen chamber doesn't cause any changes, so it's not effective. So don't expose your patients to this procedure that is not going to improve. So here at the School of USC, we have a protocol that is not based on any literature, but it has been working for us in order to prevent complications. So for those patients that are in risk and having multiple comorbid diseases, we give the education and the consent form. We place the patients in chlorhexidine 3 times a day for 1 week pre-op, and after, until healing is completed, we prescribe systemic antibiotics 3 days prior to the procedure and 4 days after procedure. And in some cases, if there is a candidiasis at the same time, we will prescribe the nystatin rinses, and we will do a continuous follow-up. For those patients that they already have the condition, we keep them in constant chlorhexidine, and it's important that we explain to the patient that there is a risk that the teeth and the tongue are going to be change color, especially this dark color, because sometimes they get really scared. And in some cases, we may have to add 1 in 100,000 units of nystatin just to complete the healing. And advance the surgical therapy, and also, if it's needed, if there is an active infection, they need to be placed in antibiotic, and they constant consult with the oral medicine patients. So here we have a patient that he's 80 years old with a stage 4 prostate cancer with colon metastasis. He was in IV bisphosphonate for months for 2 years when he came. And you can see here the lesion, how extensive it is, the patient in severe pain. And here we have the x-ray of the patient. So when you see, you can see all the bone and the bone exposure. Okay? And this was in 2008, and 6 months later, the area has regenerated a little bit. And here, after 2 years, is much better and completely healed, or still with some areas, but much better condition. So sometimes this patient has to be in continuous use of chlorhexidine, depending on how sometimes the bone is exposed again, and they will recover the epithelium, and they go back to the exposed bone. And this is another case, and the difference with this case is that this patient, that is a 70 years old Asian female, was using only oral bisphosphonates, Fosamax, once a week for 1.5 years. And you can see the lesion here. So the debridement was important. You can see the lesion radiographically. With this, the remotion of the lesion, and now we are waiting for healing.